Yeah.
Yeah. Good evening, everybody. All the listeners who have joined in and logged in from the various parts of the world to listen to Dr. Amar Bide. I welcome you all. This is a unique webinar that we are having today. And I think probably one and only benefit of having Corona lockdown, that we are going to have such stupendous knowledge sitting at the comforts of our house. I'll request our president, Dr. Rajiv Laul, to introduce Dr. Bide, though it is just a formality, but we are following protocols. We have four people right now on our panel, Dr. Rajiv Laul, our president, Dr. Datta Panandikar, our secretary, and of course, Dr. Bide. So over to you, sir, Dr. Laul.
Okay. Good evening, friends, and a warm welcome to all participants to this live international webinar organized by Team 2021 Thane Obstetrics and Gynecological Society. The webinar's organizing secretary is Dr. Datta Panandikar and webinar moderator is Dr. Swarupa Iyer. The topic for today's webinar is first trimester screening. Friends, when we talk on this topic and discuss this topic, it will help us separate some myths from facts, such as whether maternal blood contains DNA from baby and placenta, whether ultrasound is necessary if NIPT has been performed, is ultrasound necessary for dating of pregnancy, and so on. It is indeed a proud privilege for me to welcome to this webinar our star international speaker, Dr. Amarnath Bide, who is a consultant in obstetrics and fetal medicine at St. George Hospital in London. He is a lead for day assessment unit and honorary senior lecturer at St. George University of London. He is co-director of MFM subspecialty program, deputy chief editor for AOGS journal. His research interests are placental physiology and pathology, hypoxia and fetal cardiac function. Clinical interests are invasive prenatal diagnosis and therapy, multiple pregnancy, and problems with fetal growth. His publications, he has close to 180 peer-reviewed articles published and many book chapters. And also he has co-authored 5 books. With this brief introduction, may I now request Dr. Amarnath Bide to start his talk on first trimester screening. Over to you, Dr. Bide.
Yeah, just before that, all the participants have a request to type in your questions so that we can take it at the end of the session. And I request all the panelists to mute their audio before we go further. Over to you, sir.
Well, thank you very much, Dr. Lowell, for the very kind introduction. And good evening to everybody. Thank you for asking me to talk about first trimester screening, and I will try my best to tell you what is happening in the field right now. So the title says it that it's a changing phase of aneuploidy screening, which indicates that the field is rapidly changing, and it indeed is. And as we go along, we will see that there are many changes which have happened over the last 10 years or so. And I'll try my best to enumerate all of them. But before we actually start talking about aneuploidy screening or first trimester screening, I think it's important for us to revise this knowledge is essential for us to understand how screening works and what the different terms used in the field of screening they mean. So the first term that we need to know is what is called a sensitivity. And the sensitivity is defined as abnormals with abnormal result. So we do a test on a population. The proportion of abnormals which come up with an abnormal result of the test, that is called as sensitivity. We also talk about false negative rate, and that is abnormals with normal result. We talk about false positive rate, normals with abnormal result. We talk about specificity, and that is normals with normal result. And that equals 100 minus false positive rate. And lastly, a very, very important term called likelihood ratio. Likelihood ratio is proportion of abnormals divided by proportion of normals. So as we go along, we will realize that these terms are used very often in the field of screening. And it is important for us to know the definitions of them. So here we've got some distribution of results. And this is the test result on the y-axis. Do you see my arrow on the screen, which I'm moving? Yeah. So these are the results in the normal group. These are the results in the abnormal group. And you see that if you draw a line over here, it clearly separates the normal group from the abnormal group. So we do a test. If the result is less than that, then we know that there are no abnormals in this group, in this part. If the result is above that, then there are no normals there. All of them are abnormals. You see that? So this is a perfect test. A perfect test has no test results which are in the normal range for the abnormal population. And there are no results in the normal range for the abnormal population. There is a clear-cut separation. Can you see all that? So this is a perfect test, and I'm afraid the perfect test almost does not exist. So all tests show a combination of that, and this is a bad test. It shows you a distribution of results. The distribution of results for the normal group is here, the abnormal group is here. There's a lot of overlap. Can everyone see that? So the false positive rate, if we draw a line here, 5% of the population above this we call abnormal. That is 5%. 5% of the abnormal of the normal group we are going to call as abnormal result. But if we use that as a cutoff for 5% false positive rate, there are only 4 out of 50, that is 8% of the abnormal group which are being recognized or detected. So the sensitivity is about 8%. No good. Yeah, there's a lot of overlap here. Is not a good test at all. This is an example of a realistic test. So this is how things work with most tests which are actually currently in use. So there is distribution of the normal group, the distribution of the abnormal group, but there is an overlap. The overlap is not much. So we draw a cutoff here, then all this we call normal, and there are some abnormals there. And all this above this we call abnormal, and there are some normals there. Can everyone see that? So the false positive rate is 5%. 5% of the normal population we are going to call screen positive. But in that 5% of the normal population, this group, we have got 33 out of 50 of the abnormal group also being detected or called screen positive. So the sensitivity here is 33 by 50, that's 66%. Okay, so that's how most tests work. There is some overlap between normals and abnormals, but the overlap is not much. Okay, so if we want no false positives, then we are going to have to draw a line here, whereas all the normals will be below that, but then we will miss quite a lot of abnormals as well. Okay, so it's a trade-off between sensitivity and a specificity. So now that's the cutoff that we're talking about. If we want no false positive, 0. If we put a cutoff here for 3% for false positive rate, the sensitivity becomes 50%. For a 10% false positive rate, sensitivity comes up to 80%. And for 50% false positive rate, you have 100% sensitivity. Okay, so by playing with the cutoff, you can decide how much the sensitivity you can achieve. But this sensitivity increase comes at a price. The price to pay is increase in the number or proportion of false positives. Okay, so that's the price to pay. Right, some facts we need to know about. That's the background risk. As the maternal age increases, the risks of some chromosomal abnormalities increases, and that includes trisomy 21, trisomy 18, trisomy 13. So these are the commonly seen chromosomal problems in clinical practice, 18, 13, and 21. Whereas for 45X, that's Turner syndrome, triploidy, and sex chromosomal trisomies, the rate does not increase or not related to maternal age. That's something which we need to remember. The second thing we need to remember is the lethality, intrauterine lethality of chromosomal abnormalities. And here you see, if we start at 10 weeks, by the time we come to the end of pregnancy, a large proportion of triploidy have already miscarried, or these babies are no longer there. Okay, so that rate is about 12% in trisomy 18, 15% trisomy 13, 20% in Turner's, only 65% in trisomy 21, and almost all will carry on till term if it is a sex chromosomal triploid trisomy. Yes, so it's important to realize when we are talking of what is the likelihood is higher the earlier in gestation we are looking at. So as we come close to the end of pregnancy, the rate goes on decreasing. So there is some intrauterine mortality, and it's nature's way of sort of dealing with abnormal pregnancies. Now, previous chromosomal abnormalities, that gives or constitutes an additional risk of about 1% or 0.75%. over and above the age-related risk. So armed with these three, this information, then we can talk about first trimester trisomies, screening for abnormalities. So here is the same principle that we are talking about. Depending on the cutoff, we can increase the sensitivity, but we also increase the false positive rate. Lastly, this important principle, likelihood ratio. Likelihood ratio is of two kinds: positive likelihood ratio, that is proportion in abnormals divided by proportion in normals, and a negative likelihood ratio is proportion in normals divided by proportion in abnormals. Okay, so now we can talk about screening tests, and we start off with maternal age. And we know, we've seen that as age increases, the risk for chromosomal abnormality increases in most common trisomies. We are talking of Down syndrome now. For Down syndrome's sake, when the slide was made, approximately 5% of the population, pregnant population, was above the age of 35 or so. And only 30% of babies with Down syndrome had advanced maternal age. And this is the sensitivity. So if we use only maternal age, then we will call 5% of the population as high risk because of their age, but that will include only 30% of babies with Down syndrome. So there was a lot of overlap, and it was not a very good test. Then we came up with the fetal nuchal translucency at 11 to 14 weeks, and that made a lot of change. At 5% false positive rate, now you've got a detection rate of 75%. That means 3/4 of all babies with Down syndrome will be labeled as high risk with maternal age, combination of maternal age and fetal nuchal translucency at 11 to 14 weeks. If we add maternal serum biochemistry, that is the combined screening as is done in the United Kingdom, then for 5% false positive rate, the detection rate goes up to 90%. That's pretty good. Of the population as high risk. And if we add some more, maternal age, nuchal translucency, nasal bone, and first trimester serum screening, for a 2% false positive rate, one can achieve a sensitivity or detection rate of 95%. That is pretty good, okay? As opposed to that, if we miss this window 11 to 14 weeks, then all we have got is maternal age and serum biochemistry at 15 to 18 weeks, and that's the quadruple test, which is not as good. You can see that false positive rate of 5%, the detection rate is 60 to 70%. Okay, it's not as good. Then we have got another opportunity, and that is ultrasound scan for fetal defects and markers at 16 to 23 weeks. And that has got a false positive rate, which is relatively higher, 10 to 15%, and the sensitivity was about 75%. Yeah, so not great. And that's why the current standard for first trimester screening is the combined screen, which is this: maternal age, nuchal translucency, and serum biochemistry. Okay, now there are some changes, or quite a lot of changes, in the way the genetics of this works. And I've got here the standard karyotype here, and it shows standard karyotype shows the chromosomes. It doesn't actually look like this unless the cells are dividing. So we can't see these kind of chromosomes in an interphase phase of the cell division. When the cells are not dividing, you don't see the chromosomes. So in order for you to see the chromosomes, you've got to make the cells divide in some way. So that requires a culture. Now, culture is something like putting seeds in the ground and waiting for the tree to grow up. And that obviously takes time, and we don't have that much time. So what scientists did is that they asked the question, is there any possibility that we can get a result pretty quickly? Because once you, for example, you do a test like a CVS or an amniocentesis and send it to the lab, they will culture the cells. They'll isolate the cells and they'll culture the cells. And the cells will be made to divide, and that takes between 10 and 15 days for the cells to start to divide and grow. And that's a long time. And people, if you do a test now, the parents want the result straight away. So is there any way to hasten these things up? And there is. And this way of doing that is what is called as a quantitative fluorescent polymerase chain reaction, or QF-PCR. Now, QF-PCR testing is a rapid test. It only tests for 13, 18, 21, can sometimes do for X as well. And because it only tests for 13, 18, 21, it can miss other chromosomal abnormalities. The way in which it works is that the people in the laboratory, they identify certain markers on these three chromosomes, 13, 18, 21, and they will see how many markers are seen in a particular sample. So this is a normal sample, and you can see two markers, the two copies. So if you see three copies, you know that there are three copies of this chromosome here. But sometimes these markers are the same in a chromosome. So sometimes for a trisomy, you get a ratio of 1:2 here. You should be getting a ratio of 1:1. So these are the same copies. So there are two copies of this marker, but one copy of this marker. So in all, there are three copies here, and it's a trisomy. You see that? So either you see this, three copies straight away, or you can see these 1, 2, and 3 copies here. So that is how the QF-PCR works. Now things have moved on, and things have moved on to, first of all, it was conventional karyotype, which is this. Then I talked about QF-PCR, but now things have moved to microarray analysis. And from there, things have moved on to what is called as next generation sequencing, or sequencing of the base pair. Now that is the kind of resolution that we are looking at. If it's a large chunk which is missing or extra, that can be seen by cytogenetics. So that is the visual analysis through the microscope, looking at the karyotype. So for that to be seen, the resolution should be 5 to 10 megabases, a million base pairs. For microarray analysis, it can be reduced to about 10 kilobases. Okay, from here, it's quite a jump from 5 to 10 megabases. Even if it's a very small deletion or addition, up to 10 kilobases, microarray analysis will pick it up. With whole genome or exome sequencing, that can be reduced to 1 base pair. So it's really, really sensitive. And what these things are, we will see in a minute. What is this microarray? Microarray is called as comparative genomic hybridization. And these are the principles. It compares a normal genome with the patient genome. CGH picks up extra or missing bits of chromosomes, but not single gene mistakes. So what it is doing is the DNA is chopped up into many small pieces. And on a glass slide, there are templates of small pieces of these chromosomes, which are treated with patient sample and a normal sample. And these two samples will then compete to bind. And if there is an excess or lack of any of the pieces, then this will be picked up and that will be flagged up. Now you might ask me how many such pieces can be seen on one slide? Lots, and I will tell you how many. So it is a more detailed karyotype. Hence, if a single gene disorder such as achondroplasia is suspected, microarray analysis is not an appropriate test. It does not check for single gene mistakes, but it will check for additions or deletions of chromosomal material or DNA. Now, these many probes are put in it. There are two types, 44,000 to 1.8 million probes. So these are the samples which are put on the glass slide and which will be seen. So this is the principle. There's a glass slide. There are micro sites here, and I told you how many there are, between 44,000 to 1.8 million. So there's a test genomic DNA and a reference genomic DNA, and it is labeled with a color. So one is green, the other is red. So the result should be not green, not red, but yellow. Okay, so if there is an excess of the test genomic DNA, green will predominate. If there's a loss, then reference genome will predominate and you will see a different color. You see that? So DNA gain will be seen with green color and DNA loss will be seen with red color. And neither loss nor gain will be seen with yellow color. Yeah, so a ratio is calculated. Normal ratio should be 1:1. And if the ratio is higher here, you see DNA gain. If the ratio is less than 1:1, there's DNA loss. Am I making sense?
Yes, sir.
Okay, so the computer analytical software calculates the ratio of the red to green dye and produces results showing the areas of imbalance, the position, the size, and gene content. So this is highly sophisticated. So it can be, you see here, this is the result that you're getting, and you are seeing here there is an imbalance. Normally, you should expect it in here, in this range. So there is an imbalance, it can be mapped, and it is mapping to chromosome 9 here. You can see that. So now the entire human genome is known. We know that what genes lie on this chromosome 9, on this region, and what is their function. So we can map it to a particular chromosome. We know how much excess or deletion is present. We know what genes are involved, and we know what effect it can lead to. Okay, so all this is known now, and that's how CGH or array CGH or microarray testing is important. Now, question comes up is, are there any advantages of using microarray? So this is a paper published in 2012 where people did normal karyotype as well as microarray, and they tried to see what is the additional information that is available from microarray. And what they saw is that it is dependent on the reason why the test was done in the first place. If the test was done only for advanced maternal age, then there is an addition. So less than 2% of all the samples, there will be additional information available from microarray. As opposed to that, if there's an ultrasound abnormality, then that jumps up to 6%. Yeah, so there's a reason to suspect that there will be some problem there. So these are samples with normal karyotype, but abnormalities are seen on microarray. So this would not have been picked up with a normal karyotype or visual karyotype. Am I making myself clear? So there is additional information, and that depends on why the test is being done. If it is being done for ultrasound abnormalities, then the yield is high. And that's why these days we'll consider microarray if there is an ultrasound abnormality seen while screening. This is a systematic review and meta-analysis of several trials, which shows that overall 8 to 9% of cases with abnormal ultrasound findings, there will be additional information with microarray. Yeah, so we saw only one study earlier. This is a meta-analysis of many studies, and it is showing more or less the same. Yeah, 8-9% additional information, and this is the additional information that you get. You see, normal ratio should be 1. Here there is a loss, and it can then be mapped up. Okay, and there are several resources available. These are the ones which are almost freely available on the internet. Now, this is not something that we do as clinicians. This is something that geneticists will do. Once they know that there is an imbalance, they can map it, and then they will tell us what is the likely effect of that. Yeah. So it is really important for us to be constantly in conversation or dialogue with our genetics colleagues. They tell us what we should be looking for, because they say that, okay, we are seeing so and so, and this is likely to result in such and such. So please look at it. Look for that when you're doing a scan. Yeah, so we are much, much better equipped by the knowledge as to what to look for. And that's the importance of talking with geneticists. Now there is an advance here, something called as exome sequencing. What is this exome sequencing? This is an efficient strategy to selectively sequence the coding regions of the genome, which represent 1 to 2% of the entire genome, but contains about 85% of the mutations that are known to cause genetic disorders. Yeah. So what we know is that from all the human genome, about that much is the coding one. The rest is all junk. Yeah. So this is the important one. So if we can concentrate here, then that is what we can pick up. And this is actually sequencing the genetic code of the DNA. It is cheaper but effective alternative to whole genome sequencing. The alternative is to sequence the entire genome. Yes, but this is available when we are getting sample from the baby, yeah, or the placenta. So we've done a CVS or we've done an amniocentesis. You got a sample, you got DNA, and that DNA can be tested. And we can actually sequence the DNA of the fetus. So that is called whole genome sequencing, which is expensive. We can't afford to do that. So that's why these days we will, in selective cases, do exome sequencing. Okay, so this is a slide which is a relatively old one, 2018. If the risk of aneuploidy was 1 in 150 or greater on combined screen, then what we would advise is invasive testing with QF-PCR and sex chromosome ratios only if nuchal translucency is more than 4 millimeters. Am I too fast, or am I making sense? So here, if the risk of aneuploidy is 1 in 150 or greater, then we know that the chances of Down syndrome, Edwards syndrome, Patta syndrome are high. So we would advise this invasive testing with QF-PCR. But we know that in a large proportion of Turner syndrome, sex chromosome ratio, the nuchal translucency is more than 4 millimeters. And that's why if chromosome ratios, if the nuchal translucency is more than 3 millimeters, then it's treated as an ultrasound abnormality and we will ask for a full karyotype. If there are ultrasound abnormalities seen, then we would ask for full karyotype and we will ask for CGH offered. That's a microarray analysis following discussion with genetics. Yeah, so this was the case in 2018, and that's now has changed a little bit. That brings us to the topic of cell-free DNA in maternal blood, and this is a hot topic right now. So we do know that maternal blood has cell-free DNA, average of 150 base pair length. This is a mixture of maternal and fetal DNA. The fetus and placenta is mitotically active. So proportion of DNA of fetal origin is relatively large, 10 to 20% of all free fetal DNA is, rather free DNA is fetal and placental in origin. It is possible to differentiate maternal and fetal DNA for NIPT, but it is not essential. Now, these days, they will find out what is the fetal fraction of the DNA. But actually, it is not essential to differentiate fetal from maternal DNA. And I'll tell you how it works and why not. Okay, so here is a sample of maternal blood. And there are millions of cell-free DNA fragments in maternal plasma. So what is done now? Now these fragments, as we see, are on an average 150 base pair in length. So what we can do actually in the lab, we will start to sequence the fragment. This particular fragment, we try to sequence it. And the longer the fragment is sequenced, the more unique it becomes. Okay, so it is possible to know exactly where that fragment has come from. And it is possible to map it to that particular region. Okay, so this is how sequencing works. What we are doing is we are actually mapping it to a particular chromosome. Do you see how it works? So we know that these are all mapping to chromosome 14. These are all mapping to chromosome 13, to 18, to 21, to X. You see that?
Yes, sir.
Okay. So it is possible to map it to a particular chromosome. But if the baby has excess of chromosome 21, then that is what is going to happen. Okay, so we are going to get equal ratio here from the maternal and fetal, equal ratio from maternal and fetal. It comes here. There is a higher dose of chromosome 21. Can you see that?
Yes, sir.
So here the ratio is going to change. Yes. So by counting how many, so there is going to be an excess of chromosome 21, material coming from a chromosome 21. And we know that mother is not having Down syndrome. So the only source of this 21, extract 21, must be the fetus. Okay, yeah. So that's how non-invasive diagnosis works. In trisomy 21, cell-free DNA fragments from chromosome 21 are in fetal. So this is highly sensitive. Okay, and all these techniques are very much dependent on statistics. The larger the numbers, then the statistical variation becomes less and less and less, and we can be more and more accurate, and we can be more and more sure that the difference in ratio is actually real and not by chance. One of the first techniques for pre-fetal DNA analysis is called as MPSS, or massively parallel shotgun sequencing. Yes, so in that, what the laboratory people did was that they sequenced each and every fragment from the blood, and they mapped it to a chromosome. Yeah, so that was relatively intensive, and they had to count 1,000 fragments, okay, for each chromosome in order to get reliable ratios. So that is a lot of work. You see what I mean? So this, although MPSS or massively parallel shotgun sequencing is the beginning of free fetal DNA techniques, this is not used. This has been modified and has been improved. And these are the two techniques which are largely in current use. One is called DANSR, or digital analysis of selected regions, which is used by Harmony test. And I'm sure everybody has heard of Harmony test. Yes?
Yes, sir. Yes.
The other one is called SNP, or single nucleotide polymorphism analysis. And that is something which is used in Panorama test. Yeah, so people have used a Panorama test as well. They've heard of it. So these are the two, these two techniques are the commonly used techniques available right now. Yeah, and all the laboratories which are offering NIPT right now are using modifications of this or this. So these are the techniques which are currently in use, available. It's a figure showing the fetal fraction, how much of the DNA is coming from the fetus in the placenta. And you see that on an average, fetal fraction is about between 9 and 12%. So that's the kind of proportion of all free fetal DNA, which is of fetal placental origin. Now, obviously, it's a distribution. And on one end, we got a very small proportion. On the other hand, it can go up to 30% of all free fetal DNA may be, rather cell-free DNA may be fetal. But if we come to this end of the tail, then we know that only a small fraction of the cell-free DNA is fetal. And in that case, detecting an excess becomes more and more difficult. Yeah. So if you are here or on this side, then detecting an excess is easy. But when we go here, detecting an excess is really difficult because only a small proportion of the entire cell-free DNA is of fetal origin. Now, this is the current state screening for trisomy 21 from 1960 to 2020. And we are talking of a hypothetical sample of 100,000 pregnancies in which we expect 200 pregnancies to have trisomy 21 and 99,800 normals. Yeah, so it's a hypothetical cohort of pregnancies. The method of screening, detection rate, and false positive rate. So we start with maternal age. Detection rate is 30%. So out of 260 will be detected. False positive rate is 5%. So that is the number which have been identified as falsely positive. Yeah, 5% of 99,800. Yeah, am I making sense?
Yes, sir.
This is serum biochemistry at 16 weeks. That is 70% will be detection rate. So 140 out of 200 will be detected, but 4,990 will also be labeled as high risk. Yeah, so these are screen positives. Combined test, 90% detection rate. So 180 out of 100, those 200 will be detected. So that's really good. But here is the problem, 5% false positive. So we are calling 4,990 as high risk. Now this is combined test plus, and that is adding nuchal, nasal bone, 97% detection rate 194, but 3% false positive. Still, quite a lot of them are still being detected as high risk or screen positive. And see how that has changed with cell-free DNA. Cell-free DNA has a sensitivity of 99%, so 198 out of 200 are detected. Yes, but see what has happened to this number here. And this is the most revolutionary result. False positives, 80 of them will be called false positives. So up to here, if a test result comes as high risk, it's more likely to be normal than not. Yeah, screen 194 abnormals and 2,990 normals. But here, if the test result comes back as high risk, it's more likely to be abnormal than normal.
Right.
Okay, so here is a sea change which has happened with the introduction of cell-free DNA. So this is the current practice. If the risk of aneuploidy is 1 in 150 or greater on combined screen, then invasive testing with QF-PCR is what is still offered. If the nuchal translucency is more than 3 millimeters, then we will offer a microarray analysis. Or we will give a choice to the patient of NIPT. And what the advantages are, we'll come to a little bit later. If there are ultrasound abnormalities found, then we will offer QF-PCR and microarray as a routine. And then exome sequencing offered following discussion with genetics. So this is particularly if ultrasound abnormalities are found and we find that microarray analysis is normal, then this is something that we will consider after talking with genetics. Yeah, so this is the current practice, and that has changed the last 2 years, and we can see how this has changed because this is something which was not available till 2 years ago. Okay, so this is the nuchal translucency screening, and this is the reference range here. Can you see that? So that's the reference range, and these are all nuchal translucencies of babies who are affected by trisomy 21. Yeah, so you can see that a large proportion have got increased nuchal, but there is quite a few cases here who are also having a normal nuchal translucency. Yeah, so there's an overlap here. This is what is seen with NIPT. These are the risk of trisomy 21 with normals, and here risk of trisomy 21 with abnormals. You see there's a clear separation here. There's quite a lot of overlap here. There's no overlap here. Yeah, so all the abnormals are detected up here, all the normals are down here. So those are the risks of trisomy 21. Yeah, so the test works really well for trisomy 21. Yeah, these are normals here, the abnormals there. It doesn't work as well for trisomy 18. You see that? These are the trisomy 18 ones, and age-adjusted probability of trisomy 18 is not all on the right-hand side, but it is somewhat on the left-hand side as well. And that's the result for trisomy 13. So it doesn't work as well for 13 or 18. It works really well for trisomy 21. Now, we must refresh our Bayes theorem. Bayes theorem is prior odds into likelihood ratio gives you posterior odds. You think I'm talking Greek and Latin, but
yes, sir.
I'll give you an example how it works. So for combined test for trisomy 21, likelihood ratio is about 30. Yeah, sensitivity is 90%, false positive rate 3%. Likelihood ratio is 90 by 3 is 30, and likelihood ratio of negative test is 10 by 97 is 0.1. Yeah, so that's how likelihood ratios work. How do we actually use these likelihood ratios? So we talk of anybody across the board. The risk for anybody to have trisomy 21 is, we take it as 1 in 250. Yeah, so that is 0.04. Likelihood ratio of 30 gives us post-test odds of 0.04 into 30 equals 1 in 0.12. So post-test probability comes to 10%. So don't worry too much about the mathematics. It's important to realize how we can calculate the post-test probability. So we have done a test, the nuchal translucency is increased, likelihood ratio of 30. So that gives us a chance that the patient really has got, or baby really has got trisomy 21 is about 10%. Okay? This is an example I'm giving you. At the same time, negative predictive value of combined test, we know. So post-test probability of a negative test is that. If the nuchal translucency is normal, then chances that the baby will have Down syndrome likelihood ratio of 30. Now we come to NIPT. Where is the likelihood ratio here? 634. Yes, combined to compared to 20 or 30 rather for combined test. And that can give us the post-test probability. If the result comes positive or high risk, the chance that the baby will actually have trisomy 21 is 71.7%. And that's probably approximately what we see in real practice. If we do an NIPT, the NIPT result is positive or high risk for trisomy 21, the chances that the baby will actually have trisomy 21 is about 70 to 80% across the board. Okay, so two important things to remember. One is, if the result comes as high risk, it does not mean the baby has got trisomy 21. Yeah, there's a 70, 80% chance. So there is still a 20 to 30% chance the baby is normal. Yeah, so that's important to find out whether or not the baby really has that. So it needs to be followed up with an invasive test, either an amniocentesis or CVS. The other thing to remember is that the pre-test odds we are taken is 1 in 250. Yeah, but that's across the board. So if we have seen an abnormality which is typical of trisomy 21, for example, and then we do an NIPT, then this post-test probability is not going to be 71%. It's going to be almost 100%. Yeah, because we started off with much higher risk of the baby actually having trisomy 21 because we have already seen an abnormality. You see what I mean? So that is how it works. Negative predictive value of NIPT goes to that 0.0028%. Yeah, so because we're using the same numbers, the likelihood ratio of negative test is 0.007. So don't worry too much about these numbers here. Now this is the systematic review meta-analysis of NIPT for commonly seen chromosomal abnormalities, and the detection rates are persistently typically high. 99.7% for trisomy 21, 97.9% for 18, 99% for 13, and false positive rate is really low. Yeah, but it's important to remember that it's still there. It's not zero. The false positive rate is still there. So then, there are some pros for NIPT. The pros are, it avoids invasive testing. It massively reduces false positives. But there are cons. There are some downsides. What are the downsides? It's expensive. There are some results which are difficult to interpret. Yeah, so it doesn't say very high chance, it doesn't say very low chance, it says somewhere in between. The other one is the range of abnormalities currently detected is less than that with invasive testing with microarray. So it will only test for 13, 18, 21. It won't test for the additional problems that can be detected with microarray. Yeah, so those are the downsides of having an NIPT. You can't diagnose anything more than 13, 18, 21 at the moment using an NIPT. And things might change, but this is how it is at the moment. So thank you very much for listening to me. And if you have any questions, I'll be more than happy to answer.
Thank you, sir. That was really elaborate. Few things, though, even I couldn't understand. I think we'll take that in question answers. We have few questions. We'll go one by one. Dr. Samir Pradhan himself has asked some 2-3 questions. So I'm just going to take one by one. Is the prophylactic dose of low dose aspirin 150 milligrams after aspir trial, or it is decided by BMI, or what is the advantages of dose of 75 versus 150?
In the trial itself, if you look at the aspir trial, now this is, we are, diverging a little bit. We are going into preeclampsia rather than chromosomal abnormalities. Anyway, so if you look at aspir trial, the trial is actually did not adjust the dose depending on patient's weight. they that's what I think we should use, because those are the results that they've got. They've shown a considerable reduction in severe preeclampsia before 33 weeks, 70-80% reduction using a dose of 150 milligrams a day. So I think that's what we should be using.
Okay. Is the risk of dual marker is more than age risk but less than cutoff? Do we require additional testing?
I'm afraid I didn't get the answer, the question itself.
Actually, even if risk of dual marker is more than the age risk but less than the cutoff, I mean, when we are doing, do we require additional testing? I mean, the dual marker comparative risk has come more than age, risk for age, but it is less than the cutoff for that group. So do we need additional testing?
Okay. I think it's important to understand the concept of cutoff. Okay. So in the UK, we use a cutoff of 150, 1 in 150. So anything which is risk is less than 1 in 150 is called low risk. Any risk higher than 1 in 150 is called high risk. Okay.
Okay.
That's how it is used, but it's a little bit nonsensical if you ask me. Okay, it's important to know and realize where patient comes from. For example, somebody does a test and the risk comes to 1 in 149. What do we do with this? 1 in 149. What do we do? How do we look at this? How do we interpret this? So there are two ways in which a patient comes to this risk of 1 in 149. Okay, for somebody who's 19-year-old, who's got no prior history, fit and healthy, okay, her age-related risk may be something like 1 in 1,000. That risk has increased to 1 in 149. Am I clear?
Okay, sir.
As compared to that, somebody who's pregnant at the age of 43 has got already a baby with trisomy 21 in the past. So that person's background risk was, let's say, 1 in 50. And that person after the test has come to risk of 1 in 149. Okay. So for both these people, the risk is 1 in 149. But for the first person, it's an increase in the risk. For the second person, it's a decrease in the risk.
Right.
You understand?
Yeah,
so,
got it, sir.
Yeah. So it is important to actually to understand how one comes to the particular risk, whether it's an increase or whether it's a decrease in the risk. By the end of the day, the risk for the individual is 1 in 149. Yeah? And then we got to think about where we go from there. What does the patient want to do? So what we would do is say to the patient, like, look, this is where you were, this is where you are. What do you want to do? These are the options. What do you want to do? That's what we will talk to the patient.
Okay. So there is one question by Dr. Prerna. What extra tests to be done in case of anomaly which could not be diagnosed on double marker, quadruple, and NT scan and anomaly scan? And when patient delivered, she had some skin anomaly. There was absent epidermis, and her torch, everything was normal during antenatal period.
Okay, it's a difficult question, and it's difficult to find out what may be abnormal in an individual case. But in general, we must realize that there is no test to detect normality. We have no such test. Okay,
Right.
we only have test for detecting an abnormality, and the test that we propose to do depends on what is it that we are looking for. Okay, so we have got some tests for looking for chromosomal type of abnormalities. Yeah, and chromosomal abnormalities may be missing or extra. whole chromosome or missing or extra part of the chromosome. Okay, so it's like going to the library and looking for a book,
Right.
or look at entire section of books. That's a chromosome. Okay, we look for a particular book in one particular section. That's like doing a microarray analysis. If the book is not there, or there are two copies instead of one, then we know that there is a problem. Okay, so that's a microarray analysis. What the microarray analysis does not do is to find out if there is a spelling mistake in any of the book pages. Yeah,
Right.
we know that. And for us to know that, we've got to actually read the book. Yeah,
Right.
mutation analysis. And that's completely different from microarray analysis or even exome sequencing.
Right. Now, sir, I have a few questions just in added to your presentation. Now, I think this quantitative fluorescent PCR, it is not done that commonly in India. Probably it is interface fluorescent in situ hybridization. That is what we do, fish. So, do we have any advantages of one over another as far as test results timing is concerned and the false positive rates of both?
I'm afraid I don't have the answer because I'm not a geneticist. Yeah, I don't work in the lab. I can only tell you what has happened in the scenario, in the scene, in the UK scene. Now, nobody uses fish here. They don't use fish anymore. Everybody's moved over to QF-PCR.
Okay.
So there must be a reason why fish is no longer used.
Okay, because we are using fish here more, so I really wanted to know. Now, another thing, as that doctor asked about the problem with epidermis, so there will be always some single gene mutation or single point mutation which will be missed. So even in cell-free DNA testing, do we have a facility for like typing the whole genome or karyotyping? Do we do that?
No, no, definitely not in cell-free DNA, because cell-free DNA comes in pieces. Yeah, it's chopped up pieces.
Okay.
So it's not possible to sequence the genome because we don't know the genome. Yes, so it's not possible to do that. For that, we must get a sample from the baby. So it must be having amniocentesis or CVS. Preferably amniocentesis, because CVS is only placenta. It's not the baby.
Okay.
So most people will look for fetal rather than placental sample. That's where they will start from. Now there are some tests which are now offering extra testing about over and above 13, 18, 21. Like some are offering mutation for DGeorge or DGeorge deletion. Yeah, so they're offering that. But we don't know how the tests perform. We don't know what is the false positive rate, what is the sensitivity. We have no idea because this data does not exist yet, has not been published. Okay, so the companies will offer the test because it's available, it can be done. But how to use it, the company is not going to tell us.
That is right.
So at the moment, at least, it does not make sense unless we know what it means. It does not make sense to ask for it, because it's impossible to say. If a person comes up and says, okay, I've got this test result and it's showing high risk for DGeorge, what is the chance that my baby actually has it? And at the moment, it's impossible to tell.
Right. And sir, my last question is, what happens to NIPT or cell-free DNA in case of multifetal gestation?
Okay. There are studies now increasingly being published, multifetal pregnancy, and it seems to be as good actually for multifetal pregnancy. The only thing that it won't tell us is that which fetus.
Exactly. So. So even if we find out that there is some abnormality, how do we see? Unless we get some even sonographic markers for that baby.
No, in that case, the only way to do that is an invasive testing. But in the large majority, it is not going to come as a low risk result. In that case, there is no further testing to be done, because all it gives is a reassurance, and it's a good way to reassure, because the test works almost as well, particularly for trisomy 21, even in fetal pregnancies. Now, if it's 13, 18 we are talking about, then most of these babies will have feature.
Right.
For them.
We are, yeah. Meanwhile, Panandika sir and Dr. Lowell, can you unmute yourself?
Yeah.
And both of you, sir, if you have any questions.
I wanted to ask actually this, an extension of the question that you asked him, that like he said, they have all moved on to QF-PCR and we are still doing fish here. So what do you think are the problem we are facing by still doing fish here and we have not yet moved on to QF-PCR?
I don't know, Datta. I have no idea. I don't know why people are not doing QF-PCR, to be honest.
Okay. So that was one of the questions, because when you're talking, just realize that QF-PCR is what everybody is doing, but we are still doing most of the labs, and even the best labs in Mumbai are still doing fish. The only good point is we get the reports very early, and probably it reassures the parents that everything is normal when there is an abnormal, say a dual marker test.
Yeah.
But even QF-PCR gives the result in similar time. I mean, the time duration, both tests have same.
Yep.
So we don't know why. Maybe the cost, sir. I don't know. I mean, how much QF-PCR cost and how much fish cost.
To be fair, I don't know, but with automation, QF-PCR results are quick and they are not so expensive. But how much is not so expensive is very relative. So
that is true.
Yeah, because in so many years now, where we have done the fish test, where there has been an abnormal dual marker, I don't remember a single baby who turned out to be Downs when the fish showed that the results were normal. So I don't remember a single baby which turned out to be Downs after delivery when there was a normal fish report. So I mean, I don't know whether it's statistically significant or not.
Pass. I don't know. I mean, when we are talking of sampling, either amniocentesis or CBS, then we are talking of screening. We are talking of diagnostic results.
Correct.
So we don't expect those results to be wrong. We expect the results to be reliable because it's a diagnostic test.
Right. I think question answers wise, we have almost taken everything. We've finished. So, sir, you can have a concluding remarks.
Dr. Rajiv.
Yeah. No, are you telling me, or are you telling?
Sir, any of you,
Dr. Datta,
sir?
Dr. Datta is.
No, I thought whether she was asking Dr.
No.
We have to wind up the program. Now you are going to propose vote of thanks.
Yeah. Okay. So thank you, Dr. Amar. It was nice seeing you after so many years. And it was a very, 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 very concise and a very useful lecture from you. Of course, there was quite a bit of statistics, which was, like you yourself said, Greek and Latin. But I think you managed to convince us and make us understand how important it is to get the right test for the right abnormalities, so you get the right result to the parents. So that's very important. We thank you all from the Thani Obstetric Gynec Society, and you have the distinction of being the first international speaker for a webinar that is arranged by the Thani Obstetric and Gynec Society. I thank you so much. Thank you, Swarupa, for making this happen. She was the coordinator. Thank you, Dr. Laul. I think he's a fantastic president. And I, Mangesh Jadhav, from the Gynoscience Division of Integrace, for being our educational partner. Thank you, Mangesh. Thank you very much.
Thank you, Dr. Bide. Thank you very much.
Datta,
Thank you all. Yeah. Yeah, sir.
I have a short quiz for people. Are they interested?
Oh, good.
Yeah, of course, sir. But I'm scared now. I'm remembering my Vadia days. Yeah, sir, shoot.
A few questions. Okay.
Yeah.
I'll give you the answer straight away. So,
So problem is here participants cannot participate directly. Like even if they know the answer,
I know.
I mean, only the panelists can talk. So
yeah. So we are asking a few questions, whether it's a myth or fact.
Yeah.
The statement is maternal blood contains DNA from the baby. Is that a myth or fact?
That is fact.
Fact.
Okay. What is the real answer? Partly true.
Okay, and baby, fine.
Maternal blood contains DNA from the placenta and baby, and I've written here in the bracket and baby because most of the DNA is from the placenta.
Okay.
Most of the DNA. The question comes, if the NIPT is so bloody good, why is it that only 70% of the babies are Down syndrome or trisomy 21 if the test shows that there is a high risk? Is the occurred to anyone? If the test is so good, then why is it not 100%? Why does one have to do an amniocentesis still? And the answer is here. The answer is because most of the DNA is from the placenta. Okay, so that will be cases where some cells in the placenta are trisomic 21 and some cells are not. So this is something called as mosaic. Okay, and it's confined to the placenta, confined placental mosaicism. Okay, so there will be some cells from the placenta which are trisomy 21, and that is what is giving the test positive, okay, for NIPT. But if you test the baby is unaffected.
But so then I have a question here. Then the placental genome and the baby genome will be different. From the baby side, the placenta will have the same
Correct. So that is why it is called confined placental mosaicism. It's confined to the placenta.
Okay.
How is earlier in pregnancy. Okay. So consider cell mass, which is 64 cell size. You remember your anatomy days, morula. Yeah.
Right.
All of cells, which is the embryo, which starts from the embryo, and some of it will form the baby, and some of it will form the placenta. Right. So consider a cell mass which is 64 cells. How many cells do you think will form the baby, and how many cells do you think will form the placenta? The answer is approximately 60 out of 64 cells will form placenta, and 4 out of the 64 will form the baby. Okay, so majority of early cells go to form the placenta, and that's why confined placental mosaicism is much more common. This question comes up is, can you not have a confined fetal mosaicism? Okay, only the fetus is abnormal, but the placenta is normal. Is that not possible? It is possible, but it's far more likely that it is the placenta because majority of the cells will go to form the placenta. Am I making sense?
Yes, sir. Got it.
Okay. So that is why this is not a fact, complete fact.
Right.
What about this? Ultrasound is unnecessary if an NIPT has been performed.
Ultrasound necessary.
No, I think, sir, the answer is in your first question only, because since it is both the type of cells, placental and baby. So even if your NIPT shows, I mean, either way, if the NIPT shows high risk, you anyway have to carry on with, I mean, with ultrasound and invasive testing both.
Yeah.
Yeah.
So part of it is true, but there are other. We cannot do the NIPT before 10 weeks. So we need to date the pregnancy. We need to confirm single and intrauterine pregnancy. We don't want to miss an extrauterine one. Not all major abnormalities will be trisomy 13, 18, 21, and some structural problems will also be there. So for all this, we still need an ultrasound. Yeah. So NIPT does not replace ultrasound scan. Ultrasound scan, unfortunately, is going to stay.
Okay.
Myth or fact, fetal DNA is extracted from maternal blood.
Yes.
For NIPT.
Yeah, actually, NIPT is fetal DNA, but then in your presentation, you said it is not essential. I mean, though it can be done.
Correct. So we asked the question, combined, we asked the question, fetal DNA is extracted from maternal blood? No. All the DNA is extracted from maternal blood for NIPT. Yeah, so it's a combined maternal and placental DNA. And most of the DNA is placental. A lot of the DNA is maternal. Yeah, so 80–90% of DNA is maternal. Remaining is placental, and only a small proportion is fetal. But placental and fetal DNA is the same in almost all cases. Very, very rare that you have got this mosaicism problem. And that is why you don't get 100% accuracy for NIPT. But still, a large proportion is maternal DNA or the pre-fetal DNA. So it's although possible, fetal DNA is not separately identified. Yeah? So if we are sequencing a fragment, we don't know whether it's a fetal DNA fragment or a maternal DNA fragment. Yeah? It's almost impossible to know that unless somebody is doing what is called as the SNP analysis. So that's different. In most cases, you don't need to do that. Myth or fact, NIPT can replace amniocentesis. And I think we've already answered this question.
Yeah. Okay.
NIPT is a very good screening test. Okay.
Okay. Yeah.
Need to confirm it. There are false positives. They are more common, and false negatives, which are less common. So false negatives, again, question comes up is, if the test is so good, why are there false negatives? The question comes up, isn't it? Why should there be any test which does not show it up? Okay. And the reason for false negatives is that if there is little to no fetal DNA, then obviously it will not be picked up. So depending on how much of the total DNA is fetal and placental, okay, if it is very less, then it will be a falsely negative test. If it is not testing for fetal DNA at all, because there is not there, then it won't pick it up. Okay, so that's why most labs will run a quality test, quality assurance. Okay, and unless the fraction is a minimum 4%, they will not issue a test or result. Okay, and you will get some samples where the lab comes back and says, sorry guys, insufficient amount of DNA, so can't result, test failure. So it happens. It happens because there is too less fetal DNA. And it's interesting that it is to some extent dependent on maternal size. The bigger the mom, the higher the proportion of DNA being maternal and less being fetal. So bigger the mom, higher is the risk of test failure, because relative proportion of fetal DNA is smaller if the worm is big. So this is something which is known, and that's why you can get false negatives as well. But these are less common because labs don't issue a result unless there is enough DNA detected.
Right.
So all the questions I have, and
yeah.
Hope
we pass, sir.
To make before we wind up, I got a message from Dr. Nitin Chaubal, our ace sonologist, and he said that we have been doing QF-PCR for a long time, and we are not doing fish anymore. We are all doing QF-PCR for all his patients. So that's a good thing to hear. I think we were mistaken. So that's a very good thing to hear.
Fantastic.
Yeah. Okay. So we wind up session, sir. What is it?
Yes, I think we can wind up. We have asked him all the questions, and we have probably passed in his quiz also. So we can.
Yeah. So thank you all. Yeah. Thank you so much, Dr. Bhide. And I have to thank another Bhide, Dr. Mahadev Bhide. Because of him, the whole thing was possible. So thanks a lot, all of you. And special thanks for Dr. Bhide for taking out the time on Sunday and having this lecture with us. So I will surely look forward for another session with you in some time in future. I'm already getting queries if you can take sessions for other societies. So I think you may have to take few more sessions for us. Thanks a lot, sir.
Thank you very much.
Thank you.
Yeah, lovely talking to you guys.
Thank you.
Thanks a lot, sir.
Yes.